All right, welcome everyone. Thank you for being here. I'm going to get us started because I am really excited for every minute that we have together today. I'm Sarah Brewer. I direct our education program in the Teams Core at Accords. That's our training, education, and mentorship core. I want to welcome you all for our last in our Learning Health Systems series this year. So for those of you who aren't familiar, a little bit about Accords. What are we? We're supported by the University of Colorado School of Medicine and Children's Hospital Colorado, and we're something of a unique one-stop shop for faculty to conduct pragmatic research, receive various types of services and support for grants and projects, along with incredible mentorship, training, and education in health services research. I want to particularly point out this second bullet point here on our strong methodological cores and programs. We have 3 of our cores and programs partnered on this particular series this year. And so thank you so much to our Learning Health Systems core, our Pragmatic Trials core, as well as our Economic Analysis core this year. A couple of upcoming events just to have on your radar and in your calendars. This Friday, we have our Community Engagement Showcase partnered with our CCTSI Community Engagement Core. We'll be over in Krugman Conference Hall, and I'm really excited to have a number of our community partners here on campus, as well as a couple of partnerships we're highlighting in our program. So please come join us. April 30th and May 1st, we have our D&I intro workshop. This is entirely virtual, and registration for our didactics is still open on our website. May 12th, we have the last in our seminar series for this year, emerging topics in digital health and clinical informatics, and we'll be hosting Matt Lascalzo talking about real-world augmented supportive care. And then lastly, we have our Colorado Pragmatic Research and Health Conference, June 4th and 5th. Here on campus. Registration is open, and we are really excited to have you all there as well. Before I introduce our speaker today, just a couple of housekeeping items. First, if you are on Zoom, please use that chat liberally throughout our conversation today. We will have some time for Q&A, and I'll be monitoring that. So please share your comments and questions. And then last, at the end of our time together today, we do have an evaluation, and we hope that you'll share your feedback because that helps us with planning for all of these kinds of programs in the future. All right. I am really excited today to close out our Transforming and Advancing a Learning Health System Multiple Perspectives for Mutual Gain series. And today we welcome Dr. Jean Kutner. Dr. Kutner is a tenured distinguished professor of medicine in the Division of General Internal Medicine at the University of Colorado School of Medicine, the inaugural Chief Medical Officer of the University of Colorado Hospital, inaugural Chief Academic Officer for UC Health, and Associate Dean for Clinical Affairs for the University of Colorado School of Medicine. She is board certified in internal medicine, geriatric medicine, and hospice and palliative care medicine, and cares for patients on the palliative care service and in general internal medicine clinic. Her research focuses on improving symptoms and quality of life for people with serious illness and their family caregivers, and building capacity for palliative care research. Please join me in welcoming Dr. Kutner today. Thank you for joining us. I'll move this chair a little bit.
Well, thank you, and thrilled to be here. Thank you for the invitation. I was excited to get invited to talk on this topic, and I think, as you heard, I'm presenting in this case with my UC Health hats on, my Chief Medical Officer and Chief Academic Officer hats on, and as you heard, I'm also coming at this as an investigator myself. So I think bringing both of those perspectives and living squarely in the middle of those spaces, and so I think being able to bring both of those perspectives and understanding, and maybe this will come out in some of the discussion as well, understanding that and maybe this is one of my take-home messages as well, the sort of overall goals are the same, which is providing the best evidence-based patient care in a timely manner, in an environment where people want to seek care, and in an environment where people want to provide care. I would say 100%, those are the same goals from a researcher perspective and from a health system perspective. Sometimes how we get at that and the pace at which we get at that, and the maybe rigor at which we get at that may be different. And I think that's maybe sometimes when it feels like, oh gosh, the health system doesn't care about these things, or the health system's not responsive. And then you get from the other side of things, oh, why are things so slow in the research world? And I think that another sort of take-home message here is figuring out where that happy medium is between those two sort of perspectives that are actually trying to achieve the same thing. Let's see, look at that. So what I'll do is I know some of you know this well, but not everybody. I talk a little bit, since I'm coming at this from my UC Health leadership roles, is talk a little bit about UC Health, what it is, and then what our current priorities are as a health system, because I think this is important for researchers to know who want to conduct particularly learning health system type research or embedded research within UC Health. Is, I will tell you, it's a lot easier to sell for me if you can align it with the UC Health priorities. Not the end all and be all for everything in healthcare, but if you're looking for resources from our health system or any health system, it's usually an easier sell if you can align with the priorities of that health system. I'll give you a couple of examples, because when we were working on planning this, it's sort of my response was, we're doing a lot of this. We may not call it research, we may not call it learning health system, but there's a lot going on. And I think as I talk about my future vision, particularly with the chief academic officer role, is brand new. Was just named to it in October, and I'm still doing both roles right now, so I haven't been able to fully dive into it. One of these days, hopefully soon, I will be focusing completely on the chief academic officer role, so we'll also have more time to work with all you on that future vision, and that's where we'll end up. And then Katie and I will have a little discussion. Okay, so just a little bit about UC Health. Like I said, apologies for those of you that know this. Just want to make sure people are aware of the mission and vision. I think the most important thing for this discussion is, if you look at it, is baked into the mission of UC Health: learning, healing, and discovery. Last I heard, learning is education, our educational mission. Discovery is our research mission. And that's really where I see with the chief academic officer hat on, those are the two components of the mission that I'll be taking, or I am taking on in that role. So it is baked into the mission that we are always learning and discovering. So I just want to make sure people were aware of that and the focus on excellence. A little bit about the size and the scope. We came together as a health system in January of 2012, started with just University of Colorado Hospital and two hospitals up in the north, Medical Center of the Rockies and Poudre Valley Hospital. We are now 14 hospitals that you see listed here. And so if you look at this, not from put your mind out of market and all that, if you look at this as, look at this research laboratory you got right here. Think about it that way from your research perspective. Think about where these hospitals are, their differences in size. We've got ambulatory, inpatient, got ambulatory surgery centers, we've got freestanding EDs, we've got 2.7 million unique patients. That's pretty darn good lab for doing some interesting work with. And this just shows the spread of that. All the ones in the red are UC Health hospitals. And then you see we also have some other partners that are in the gray. They're ones that have a management agreement with UC Health. And the key thing on this is not sort of what the organizational structure is, but if you think about learning health system type research, these are all on the same instance of Epic. So if we think about in terms of embedded EHR embedded clinical trials or available data on 2.7 million patients that are all in the same instance of Epic. So that's why I wanted you to understand like what the scope is from sort of a lab perspective. We've done pretty well from a quality perspective, although we never rest on our laurels, and there is always more we can do. These are just some of the back to, what does the health system put priority on? There are many, many different ways that, health systems and healthcare get measured and reported on quality. For example, you do not see leapfrog on here. UC Health does not, for those of you that know, like healthcare rating scales or whatever, publicly reported. So we focus primarily on Vizient as our sort of true north in terms of our comparisons. And these are just different ways that we've been recognized for the quality, and it matters. If you go back to the mission, the whole point of the whole health system is to provide excellent care to patients. That's why we all do what we do on a daily basis. And like I mentioned, we are an academic health system, and the academic mission is key to what we do as a health system. Therefore, all of the things that you are interested in are key to what we do as a health system. There's as the learning, healing, and discovery from a learning perspective is that, we support the training of a good majority or a good chunk of the physicians that end up practicing in Colorado. Most of these learners actually come from CU, although there are some, learners, especially in some of the like nursing and all that come from multiple other universities. And we also, we actually, turns out we have 2 of our own residency programs, the things you learn when you're in a new role. We also support multiple clinical trials. We, at any one point in time, have about 1,700 clinical trials open across UC Health. Again, the vast majority of those, about 95% of those are CU faculty as the PIs, although we do have some community-based clinical trials open as well. And as you all know, we're the only academic medical center in Colorado, and at least so far. We'll see what happens with NIH. We have the, total research funding, which again, mostly comes to CU, not to UC Health. It's about 700 million. And then UC Health provides or in the last year provided $315 million directly to CU to support the academic and research enterprise. There's an ongoing arrangement for that. So just kind of to give you the context of who we are, what we do, what's important. Just a few other things in terms of UC Health's contribution to the health of and well-being of its communities and the state. It's one of the largest providers of uncompensated care in the state at $580 million. And we actually just released our newest community benefit report. It is on the UC Health website if you are really interested in what the UC Health community benefit looks like. And then this is often a surprise to people that UC Health is actually the largest Medicaid provider in the state as well, with about 1 million Medicaid outpatient visits per year, and year over year significant increases in the number of Medicaid patients, and about 30% of all Colorado hospitalized medical care is provided for Medicaid patients is provided by UC Health. All right. Enough about who we are. Excellent. All right. This is where I dive into what's going on at UC Health that really comports well with the learning health system concept, and I think fits well with the types of things that you all as learning health system researchers are interested in. So we are, like many other health systems, on a high reliability journey, and we think about that as high reliability for our patients, high reliability for our team members, our clinical team members, and then there's the role of leaders in high reliability. So from a patient perspective, they should experience excellence every time they interact with us, no matter where they interact with us. From a frontline team member, they should also be able to experience predictability and understand, what their roles are. They should be able to actually do their roles and not have them, other, things get in the way of being able to do their roles and make it so it isn't overly complex. And then our job as leaders is to create this predictability and set that vision. So just sort of some examples as we've been conceptualizing this. This is for the patients and the teams. Our role as leaders is to create that culture and cohesion that allows for this to happen. But for example, if you take a patient across, let's say a patient across a care journey, let's say they've got a scheduled surgery. So in the clinic setting, they should know what to expect. That should be set up for them before they even get in the door. They should understand what's going to happen when they get to the hospital. When they actually get to the hospital, people should explain to them what's about to happen, when that's going to happen, and then we need to be able to follow through. Patients need to feel that their needs are being met across it. If we're going to set up expectations for patients, we actually need to meet them. If we're not meeting them, we need to explain to them why. And they should expect from us that excellent and consistent care every time. And then after that patient say it's a scheduled surgery, after they have their scheduled surgery, they should know actually probably back from the clinic what to expect when they get discharged. Where are they going? What's it supposed to look like? Of course, it's different. Somebody comes crashing in here with a trauma. It's hard to set them up to expect that. But once they hit our doors, we should be able to then set them up to expect what's going to happen for them and to them. From our team member, that they need to then have those tools if we're going to be able to support them in the care, and whether that's through our virtual health center, whether it's through making it easy to capture data, to document, to be able to get the equipment that they need, all those things that just get in the way of people actually being able to do their jobs, the whole reason they went into healthcare in the first place. So this is a lot of what we've been working on for the last actually year. Yeah, we started with this framework last May. So almost a year ago was when we started this out. And then the other thing that we've done is actually across all of UC Health is set what are our priorities from a quality and safety perspective. Previously, we had each hospital was kind of doing their own thing. Here at University Hospital, we were working on our set of metrics. Somebody else up, Highlands Ranch was working on its set of metrics. So we've now set that these are for this fiscal year, so which we're almost done with our fiscal years. Fiscal year 25 means it started July 1st, 24, ending the end of June 25. This is where we are focusing as a health system. And this is where, as you're thinking about your projects, just a little word of advice is if there's a way that you can make them somehow fit with one of these priorities, it's going to be a heck of a lot easier to get your resources to do what you want to do. I'm not saying that everything has to, but you can almost always fit somewhere in here. So this is what we're focused on across the whole system. Responsiveness is, are we responding to our patients' needs? Are we responding to each other as well? But are we responding to our patients' needs in a timely manner and making sure that we're communicating that with our patients? Mobility, our patients, this is responsiveness is both an ambulatory, is across all settings. Mobility is primarily an inpatient measure, although going back to my scheduled surgery example, if I'm expecting my patient to be up and walking the day of surgery, I need to let them know that in clinic. So there's a clinic component to that, is setting them up for success, that, oh, by the way, you're going to be walking in the PACU. That if people don't know that, they might be surprised. So mobility we see as we're setting goals, we're assessing people's mobility, and this is all of us need to be involved with that as well. We've got a role as physicians in setting expectations for our patients. We have to be working closely with our care team members to make sure those goals are being met. We see those as being helpful for all sorts of things, is, patients, their quality of their experience, for pressure stores, for constipation, for falls, all those things that are, it's better when you're mobile, right? We are also focusing on peri-procedural safety. So this is both prevention and addressing all the things that can happen in a peri-procedural area. And then readmissions and excess days, again, that takes across the whole care continuum to address. We're also focusing on ongoing focus on mortality, which, as you can imagine, there's lots of things that go into mortality across the whole care continuum. And then hospital-acquired pressure injuries, because that's something we at least here continue to struggle with. So what I've heard for fiscal year 26 is that we are going to continue to do the work on these priorities, with probably adding one more, is what I've heard. I haven't heard a final on that, but so I think you can take this as, at least probably for the next year or two, this is what we're going to be focused on. And I don't know that I'm gonna go in the details on this one, but because I was sort of talking about it as we were going. This is some of the more details as we are working on these goals. What is it that we're actually implementing? Because it's one thing to just set out their goals, but I can't just set out their goals and say, hey, team, fix it. And this is where I think we have that really nice alignment with the learning health system concept, is we need to say, what's the best evidence? What are we going to do to change practice? And then be able to measure that we actually made a difference. And so I think this may give you some of those examples of some of the interventions that are in place or ongoing or about to be implemented, because you'll see that we started with responsiveness in the beginning, so over last summer, and we've rolled out this whole new framework. And this is a behavior change one. So this may be one of the harder type ones, because to really hit this, we need every single person who interacts with the patient as well as with each other to buy into that this is the framework that we're using. So this is one, if those of you that are interested in behavior change of healthcare workers, come talk to me. We actually have a cool thing that's going on with this. We're working with the leadership track of the internal medicine residency program on this one. That they are taking on, because one of our hardest things is how do we engage with our house staff, which here is really, our frontline clinical providers. If we don't get them engaged, we're never going to change clinical practice. So I said, I don't know how to do that. So reached out to the internal medicine, actually to the Jeff Connors, who's the head of all the residency programs, and said, I got a problem. I don't know how to engage residents in our quality initiatives. He said, oh, that's a good thing. How about if we work with one of our leadership training tracks? So where we are, so we gave the problem to our leadership training track residents in the internal medicine residency training program, and they have come up with a whole framework of how to engage residents in this process. They're also engaging the relevant attendings. So they've measured baseline. They've got an intervention that they're rolling out now, and then they're going to measure, did it make a difference? So I'm excited to see how that rolls out. Mobility, we've rolled out a whole bunch of interventions related to mobility. Some of it is measurement, some of it is training, some of it is in the EMR prompting. So there's a whole bunch of different things we've rolled out in that space that we have baseline, and we're now seeing what's happening in terms of follow-up. Readmissions and excess days, that one we're in the midst of having rolled out more around ambulatory access and follow-up appointments being those interventions. And mortality, there is multiple interventions going on. I skipped over surgical procedural safety. I'll actually show you an example of something that we did, wasn't me, the team did in that space. All right, so I got little set of things. All right, some examples. And these I'm going to give full credit, and I know these are I'm just going to give you high level. These are posters from our recent UC Health Safety Week. I'm not presenting these like I'm at a scientific meeting. I'm giving you a flavor of the types of things that are going on, just so you know. So this is one that was a collaboration between our virtual health center and our frontline teams. And the key thing here, this was getting at our mortality metric, is with the problem that we were trying to solve, is we were recognizing deterioration of patients too late. By the time it was recognized that patients were deteriorating, they were, crashing on their way to the ICU or sometimes worse. So what was implemented was a collaboration with our virtual health center that is monitoring all these patients across the hospital, that through an algorithm that was embedded into the monitoring was to identify patients who were at a high risk of deteriorating. Those are flagged. They're then reviewed by a person, and then that was part of the intervention. The other intervention was then the virtual health center was empowered to actually call a rapid response. It wasn't waiting until, because previously it was the virtual health center would recognize something, they would then try and find a bedside person who would then go and evaluate the patient and then decide whether to call for a rapid response. And we saw really rapid improvement with this implementation. You can see that kind of interrupted from the left to the right in the middle. So we had a significant increase in the rapid responses, which is what we wanted. We actually had a significant increase in ICU transfer, which is again what we wanted. And we had a significant decrease in mortality. So recognize the problem, got baseline data, intervention, and then follow-up data to show improvement. This is one in the surgical safety space. This was around post or peri and post-op venous thromboembolism in our surgical oncology patients. We recognized that the baseline data, we were having a high rate of DVTs or thromboembolism in our post-op patients. We focused initially on a population, particularly at high risk. That would be patients who have cancer, because you have a higher rate of clotting with cancer. Pulled the evidence, pulled together the relevant stakeholders, identified best practice, embedded that as a pathway in EPIC. And you can see from that bottom bar graph, once that was implemented, we had a significant decrease in our peri-op DVTs in this population. So now we're spreading the same to other surgical populations. And then this one was around door-to-needle times and obtaining accurate weight for acute stroke thrombolysis in our emergency department. Problem that was identified is that we weren't doing weight-based dosing for stroke thrombolysis, so risk of under or overdosing people, and we were longer than we wanted or longer than guideline in terms of door-to-needle time. So a couple things were implemented here was, as you see at the bottom, is that so there was streamlined communication, streamlined decision-making, and there was a scale put outside of the I mean, sometimes the interventions are sort of straightforward, and you can see from 23 to 24 increase in the percent of patients that were getting that thrombolysis in that less than 30 minutes. And then the blue part of the bars on the bottom, a significant increase in the number of patients getting the right dose. So just thought I'd share some good examples of success stories. So, okay, so now back to, you want to collaborate with UC Health on something that is along these lines. So I wanted to make sure that people are aware of existing resources that are on the source, which is UC Health's intranet. I do want to acknowledge that if there's anybody here or on Zoom that is not a CU Entrance or UC Health identity, you can't access the source. So you need a partner who can, because this is the UC Health intranet. But anybody with a CU Entrance or UC Health email address should be able to. So this is on the quality site on the source. So if you look for quality up there, as a department, there are a couple of key resources I want to make sure you're aware of. One is data and dashboards. So you want to say, oh, I've got a problem that I think I want to study in UC Health. Let me see if it actually even looks like it actually is a problem in the first place. That would be a good place to start. And then there is a process that I also want to make sure people are aware of around registries. We get a lot of requests to have a data abstraction or a registry for a number of different purposes. Some of it is around, some of like the national registries to contribute to. Some of it is to create a registry for a research project. Some of it is more related to QI, but there is a process for registries. So I encourage you to go to this process as a process to submit and say, here's what the purpose is. And that will then be reviewed. And I also want to make sure people are aware of under research administration on the UC Health source is that within research administration, I put the circle there around, there's a whole process around EHR embedded research, which will get at some of the prioritization questions. This has really been enhanced a fair amount over the last year or so. So if you didn't know this was here, it's relatively new. So within that, this is what you'll get to, and you'll see that there is information about that. If you want to do EHR embedded research, what do we need to hear from you? What information do we need? And then that will be reviewed and prioritized. There's a joint CU UC Health committee that reviews all of these requests. So to wrap it up, where do I think UC Health is on the learning health system journey? I think we're further along than we actually give ourselves credit to, or that people in generally think. So if you look at the AHRQ definition, as long as AHRQ still exists, but if you look at the AHRQ definition, so do I think we have leaders that are committed to a culture of continuous learning and improvement? 100%. I would say from the top of the health system, I would definitely say our University of Colorado Hospital, you saw our mission. That's why we're here, is to continuously learn and improve so we can provide the best care to patients. Systematically gather and apply evidence in real time to guide care, I would say in pockets. I think there's some places we're better at it than others, but I think showed you some examples of where it's working. I think, could we be doing more? Sure. Employ IT methods to share new evidence with clinicians to improve decision-making. I would say, again, in pockets. I think that the post-op DBT is a great example of that, where it's an embedded pathway. And if you use the pathway, it's really easy to do. You get the right orders and all that. And I also understand we have a lot of pathways that nobody uses. So there's like, yeah, we can embed a pathway, but then we have to get people using it, and we need to then always be checking back and saying, does it need to be updated? And if people aren't using it, why not? Promote the inclusion of patients as vital members of the learning team. I would say from a patient care delivery perspective, yes. I don't know that we've been systematic about it more on the quality improvement side. So I think that's also a place for collaboration. Capture and analyze data and care experiences to improve care. I would say again, yes, in pockets. I think in those priority areas, we are absolutely doing that right now. And then continually assess outcomes, refine processes and training to create a feedback cycle for learning and improvement. I think this is one where probably most of our health systems can continue to improve instead of, do a project. Okay, we made a difference on to the next project. It's that sustaining piece of it and making sure that if we do show an improvement, it now becomes standard practice, and then scaling. And I think this is going to help us also with having the same priorities across the system because we're learning from each other. Like the mobility work started here at university, we showed proof of concept, and now it's been spread across the system. That's the sort of thing we need more of. So I would say overall, yes, and opportunities is my assessment of where we are. So looking to the future, I think, and this is especially as I more dive into the chief academic officer role, and part of this was I actually took some of this from my original vision for the role, is I think we definitely have opportunities for enhanced alignment and collaboration between our clinical and research missions, and getting into that virtuous cycle more of clinical care informing our research and research informing our clinical care. And I think, would love that as part of this discussion going forward, is how do we bring these worlds closer together? So I'll be the first to admit that I didn't know until I became CAO that there was an Accords Learning Health System core. But I got to meet with Katie, was one of the first people I met with. And if we're really going to do this well, we can't keep operating in those silos. And I think that integrating the feedback cycles of here's how we've done. And again, I think that DVT work has really done that well. That virtual health center work has done that well, where we're constantly looking at the data and how can we iterate and improve. And then I think, figuring out what are those structures, what's that governance that we need? We are never going to have enough resources to meet everybody's requests for doing things. And I would love to be thinking about across UC Health and CU, what does that governance, what do those structures look like so that we can jointly identify where are our priorities and how do we really move things forward so that we do have this sort of envisioned future together. So looking forward to that conversation as to what that would look like and working with you all on that. I think that's it. Great. Yes. So thank you. That's what I have.
Thank you so much. Can you hear me? Thank you so much. You're welcome to sit or, yeah. So what we're going to do is we have a few questions spurred by things that we've heard from the general community. But we definitely want to hear any questions anyone in the audience has. So please either let us know you have a question or add it to the chat if you're online. So thank you so much for that. That's really helpful. And it's very exciting to have you in this new role. And excited to start these conversations and continue them with you. You talked about a lot, you touched on and suggested some things. One of the things you highlighted is all the great learning health system type work already happening at UC Health, and the appetite to do more on your end, and also on more of the faculty side, appetite to do more as well. And so there's the Accords Learning Health System core that's working towards that, but other pockets as well, whether individuals or groups wanting to do that type of work. And you mentioned pooling these folks together so that there's not silos. And I know this is evolving, but how do you have ideas on how we pool these resources to maximize impact and coordinate efforts?
No, it's and like I said, I'm on a learning curve. An individual learning health system then. Anyway, I'm on a learning curve in the new role, and a lot of what I've been doing since October has been on a bit of a walkabout to see what's already going on, where do people see needs. I think a few things. One is it's on my to-do list to pull together the pockets and it may be only educating me. Maybe you guys all know this, but to see what is our shared vision and where do we have what expertise? Where do we still have gaps? And what does that future vision look like? So that is on my to-do list to do. So hold tight.
Super. And one of the things that you talked about is an area that you want to focus more effort in is the iteration and the scale. When you think about scale and dissemination, do you have advice for others who are working on learning health system type work of the best channels to share the good work that they're doing so that it can get to the decision makers to help with the spread? Yeah,
it's a great question. And because I think I think actually both internally to UC Health, because I actually looked through to prepare for this. I looked through all of the abstracts that were presented at the UC Health Safety Week. I was like, wow, there's cool stuff going on across the system that we don't even know about within our own system necessarily. I mean, I knew about most of these because they were University of Colorado Hospital ones. So I think there's work we can do there, and I've had some great conversations. Our system chief quality officer is Jen Rabalia, and she and I have had some great conversations about the need for closer alignment between what the quality department is doing and the research world. She's very interested in that conversation and moving that forward. And I think there's probably, there's a whole book of work that you all are doing that we may or may not be aware of. Although if it's something that has, like, for example, gone through those resources that I showed you through either the the registry website or the EHR embedded research website, we should know about it. And I think one of the things now I need to do is cross that silo then from things that may have been submitted through I didn't know we had a whole research registry until about 2 months ago either. So I admit all my faults. So, we need eyes on that then connect across to quality and operations. So I think it's really linking these different components, linking research, quality, and safety and operations in a way that informs each other. So I feel like I just feel like we're so on the brink, like we have the pieces, we've got the expertise, and figuring out what that structure is that enhances that communication and that crosstalk.
Super. And I think I can speak for most folks when I say thank you for being so open and receptive, because I think, when you think about situations of silos happening and walking into this new position, it's a lot. So we're very excited. So another thing, so thinking about, the right channels to share this information, the eye of the beholder, right? And so clearly resources are not endless when folks want to do things integrated in the EHR or within UC Health, aligning with the priorities that are set. So you mentioned the quality and safety priorities. And so if someone has something that aligns with one of those particular priorities, how do they get that project to the right person who is in charge of those? Just trying to figure out yes, maybe it's aligned, but how do you let people know it's aligned and let them vet it?
I think probably the current way is that if it goes through one of those that's like existing, like the EHR embedded research portal or the registry portal, then we have a process there for connecting with the relevant sort of operators in that area. If it doesn't go through one of those, then I think this is when you get sort of all the sort of pop-ups questions, or we'll find out at some point that somebody's already working with somebody. So I think the more we can drive people through existing ways of capturing it, and I think what I would need to hear back is like, okay, then what are we missing in terms of ways of capturing that, or do we need another pathway for things that maybe aren't registries and aren't EHR embedded research? Is there something else that we may need to be connecting with there? So I think probably making those, having a sort of a standard way of entering is probably going to be the best way to do it. Because I certainly I can't memorize my own org chart. I can't imagine that you all would want to either.
I think that's appreciated. So there are a few questions on Zoom, and I want to take an opportunity to also ask anyone in the audience if they have questions. Yeah. All right, so I will walk around. All right. All right.
Sure. My name is Nikita. I'm one of the assistant professors with the Department of Anesthesiology. I'm curious to hear your thoughts about the overall strategy as a health system to ensure that the care we are providing is aligned with what matters for the patients and the outcomes and experience that are meaningful for the patients, not what we think is the best. And I am talking from my personal experience in the ICU that we oftentimes have misalignment and oftentimes find towards the end of their life that, oh, they didn't want this intubation or things like that. So I was hoping if you could comment on that aspect of that learning process and feedback.
So actually, I think maybe I heard two possibly related questions there. I think one, I think is probably aligns well with this service now, that our new service framework around the set, meet, own, which is that we would expect that everybody is having that conversation, one-on-one with the patients, so that we make sure that we understand what the patient's expectations are, what's the patient's expectations of us, and vice versa. And then we're meeting those expectations. And actually, I think I heard three things. So that'd be one. Two, are we actually aligning our care overall with the patient's goals of care? Actually, one of the initiatives, it's under a little bit, unfortunately, but it's under the auspices of the mortality goal, is that we have an identified decision maker for every patient and have identified goals of care for every patient. This is actually a journey we started on 5+ years ago, to make sure that we have a way in Epic to be able to capture that. Where what we don't have is depending on the area. So like oncology has taken ownership of this. Oncology across the system has taken ownership of making sure that they've got documentation of a MDPOA and patients' goals of care, and that they're being revisited. I wouldn't say that is 100% true across all service lines. And then the third thing, I think maybe it wasn't what you were saying, but what I heard is how do we know that responsiveness, mobility, peri-op safety, and these readmissions are actually important to patients. And that's sort of a broader issue. And we engage with the patient family council to make that linkage there when we're setting sort of the overall broader goal. So I think I heard 3 levels maybe of. Yeah. And it's such an important point because, we can think something's terribly important, and, the people we're caring for, that's not their top priority.
Yeah, thank you. Matt Winia. Sorry. Matt Winia. I have kind of 2 questions. One is very pragmatic and the other sort of conceptual. The pragmatic one is around the dissemination issue and dissemination outside of our health system. When we learn something interesting and we want to publish it, how are we ensuring that all of I'm getting at the old QI research distinction, and how do we make sure that when we learn something, we are able, right, it has the appropriate ethical review in advance and all that kind of stuff. Have we a pretty well set up process for ensuring the right level of review for the right kinds of projects to ensure that we're able to publish them? So that's a pragmatic.
Okay, let me get that one first.
Sure.
Are they linked, or do you want me to do the one then?
They can be linked.
Okay, go ahead. Go ahead then.
The conceptual one is, what makes these really interesting and important problems is that they are not that obvious how to fix them sometimes, right? And the fix sometimes ends up, pushing a bubble out somewhere else and creating a new problem. And you see that even within the framing of some of these, right? So length of stay and readmissions can be in tension with each other, in that a longer length of stay may be necessary in order to prevent a subsequent readmission. And yet, those are linked as sort of, and they probably should be. Similarly, a fall in the hospital is a never event. Guess what that does to mobility, right? That means no one gets out of bed when they're in the hospital. And we as clinicians can't even change that, right? The nurses are the ones who decide whether the patient can get up out of bed or not.
Oh, I'm going to challenge you on that one.
Okay, well, good. If I am allowed to change that, I will start doing so.
Yes, 100%.
But those issues, and I don't want to oversimplify that
Yeah.
because I don't know that I am the right person to make that decision, honestly. But those are intention, right?
Yeah.
That we never want to see a fall. We get, significantly dinged if we have a fall with an injury. And we do want people to push themselves. We want them to move. We want them to get up and stand, even when they don't feel like they're ready for it sometimes. And I find myself constantly talking to patients about, this is like your high school 2-a-day practices, man. You need to get at it. This is going to hurt and it's okay. Right.
Excellent.
Yeah. But
Yeah,
then they
yeah.
can't get out of bed without PT showing up, and we are not a rehab hospital. We do not
Yeah.
do 2 or 3 times a day PT, right?
Yeah.
All of those challenges.
All right. Sort of linked. So the first one, absolutely. I do think we need to do a better job of disseminating, and I will call myself out on that 100%. Over the last, now almost 11 years that I've been CMO, I've probably published 1 or 2 papers off of what I've done as CMO, whereas I've published 10 plus papers a year still off of my research. And I think it's getting in that mindset that this stuff that we're doing is disseminable. I've actually started what do I call it? Like clinical administrative leadership scholarship monthly works in progress, and have now developed a set of resources for publishing on this type of work, including journals, guidelines for publishing, examples, etc. And I think this is something that we need to be doing more of. I have on there what the guidelines are about when you need IRB versus not. So I think that, like, one is leading by example, 2 is helping people who may, some people, we that are in research, we can probably write an abstract in half an hour and get it sent out. But if you've never written an abstract for a national meeting, it's a daunting task, for example. So providing that venue for turning what we're doing, like every single one of the, well, maybe not, most of those posters I read from Safety Week should probably get out somewhere to be disseminated. And that is also on my list as CAO to get that happening. Because the rubrics there, we actually use COMERBS, the IRB, for all of UC Health. So it's the same rubric across all of UC Health about whether something's QI or research. We just need to get in that mindset of that's what we do. And then I think your second one is, it's true. I think as we're designing research, it's true as we're designing some of these initiatives, is thinking about what is that potential balancing measure. And actually your example of falls, we 100% said from the beginning of the mobility initiative that we're going to initially at least see more falls as we're implementing this, because you're right, if people are getting out of bed and they're not just being confined there, that's not acceptable either. And we need to then understand, how do we get people up safely? And if they are going to, getting them to the ground safely, if they do need to, so they don't have a fall that results in an injury. The DVT one, our balancing metric was, there's another patient safety metric, which is post-op hemorrhage. So we watched the post-op hemorrhage one as we were watching the decrease in DVTs. Same with like your example of readmissions, excess days versus length of stay. So I think like any, well-designed project, is thinking from the beginning of what may be unintended consequences, what may we see that we didn't want as an outcome, to make sure we're capturing that as well.
Gene, that was great. Thank you. Tyler Anstead from Hospital Medicine. I really like this analogy of the health system being a potential laboratory for collaboration. Not to maybe take this metaphor too far, but what do you see as the resources that the laboratory, university hospital and affiliated hospitals provide and can and should provide? And what are the resources that the researchers that, us should be thinking to provide? Who's providing the reagents and who's providing the beakers, so to speak? Like, how do you sort of think about that pooling of resources and who should bring what to the table?
Yeah, I think it's a great question, and I think in some ways we're still figuring that out, and I think it may depend on what type of research. Like, is it something that, you know, is pulling existing clinical data, out. So then it's probably, currently it's a shared investment in Health Data Compass. Right, that's, technically what our data warehouse is, so that would be a shared investment. If it's something that's actually physically doing something in a clinical setting, then, depending on where, where the clinical setting is, it may be a CU Medicine clinic, in which case it's a CU resource, it may be a UC Health clinic, so it may be a UC Health resource. I think, like most things, I mean, I guess if you think about it, kind of like community engaged research is everybody's got expertise they're bringing to the table. The researcher may have methodologic expertise or the greater world evidence-based expertise, and the operator, somebody who's like the director of a clinic or the medical director is going to say, okay, that's a lovely idea, but we've got this whole issue. So to me, I guess I would think about it like with that community engaged research mindset, that everybody's bringing expertise to the table. And we need to, honor both sets of expertise, recognizing that there's going to be, like how I started, there's going to be pushes and pulls on both sides. Like if you come to the health system, say, I've got this great idea. This was probably a better analogy early, like last year. I've got this great idea and I'm going to write this NIH grant that's going to fund it. I'm going to get funded in about 3 years, and because I'm going to have to resubmit it twice. And then I'm going to have 5 years of funding to do this. So in about 9 years, I'll have an answer for you. That's not going anywhere, right? And then at the same time, if there's an urgent issue that needs to be solved, from a clinical side, from an operations side, we're just going to do it. We may or may not have, the rigor and the data. So I think it's going to be really different depending on what the approach is and what the need is. Not to say one shouldn't write NIH grants that are health system related, but it's going to be a very different relationship.
I think we are coming up on our last minute or so here. So Katie, I wanted to make sure you have a chance to wrap up and last question for
So I think with our last minute, I honestly would just like to say thank you so very much. I recognize that you're still figuring things out and puts you in a very vulnerable spot in some respects, but appreciate it because I think there's such an appetite and so much excitement around your new position. So thank you so very much. And I'll leave maybe the last word for you if there's anything that you want to comment on or mention. Otherwise, we can wrap up.
I guess say thank you. Thank you for the invitation. I personally am really excited about this job. It feels like kind of coming back to my roots. Turns out I'm an academic at heart, no surprise. And, for the opportunity to be able to really bring together the expertise of our CU community and our UC Health community to, do what we all care about, which is to provide better care for our patients. Like I said, in a place where people want to be and our teams want to provide care. That's what drives me. So I'm excited to collaborate with all of you on this. Thank you.